All right, good morning, everyone. Welcome to our second community forum here on this, at least in Denver, gray, cloudy morning. My name is Nina Bastian. I'm a program manager at the Colorado Health Institute. I will be facilitating this meeting today with the Department of Healthcare Policy and Financing. I'm joined by my two colleagues on the line, Ashley Brown and Suman Mather, and we're going to go ahead and get started. So from the department this morning, we have Charlotte Christ, Zoe Pincus, Dr. Peter Walsh, and Jed Ziegenhagen with us, and you'll be hearing from them this morning. Our agenda, will spend a few moments going over some housekeeping and our goals for today. We'll spend a little bit of time talking about program review and some updates based on some feedback that we've received over the last few weeks since our first forum. We'll spend the bulk of the time today talking about how to focus the Apm One, or how the department wishes to focus the Apm One rather, through some updates to the measure set and how the program works. And then we'll reserve 15 minutes as usual for public comment at the end. So we want to just pause to share with the group the different ways in which you can participate today. So we like to use the tool Menti for these virtual sessions. We have a few questions for you throughout the meeting today, and we'll ask you to use Menti to provide feedback on specific questions that we have for you. So in order to participate in the Menti, you will need a new browser window or a smartphone to participate. If you're not able to participate in the Menti today, no worries, you can use the chat if you need to. But the Menti is nice because it captures all of the information and synthesizes it well so that you can see all of the responses together. We'll be using the Zoom Q&A feature for questions throughout the meeting. So if you have any questions as we're going along related to the discussion topics, please plug them into the Q&A. We are not going to be monitoring the chat for questions. So if you've got a question, the Q&A is the best place to go. That logs all of the questions well and the responses, and is a really easy way for the rest of the participants to pay attention to the questions and answers. So Menti, questions we're asking you, the Zoom Q&A, questions you have for us, and then the chat can be used for everything else. So any comments that aren't questions, technical issues, or if you're unable to use the Menti today, that's what you can use the chat box for. And as a reminder, today's meeting will be recorded and posted to the APM website. You'll find on the website already is the recording from our last meeting, the first community forum, if you need to catch up on that. Finally, as always, following this meeting, you can continue to reach out to the Colorado Health Institute team at focus groups at coloradohealthinstitute.org. If you have any particular feedback on this meeting, if you can get back to us by next Wednesday, we can share that with the HCPF team and get some responses for our third and final meeting. All right, and I'd like to turn it over to the Chief Medical Officer, Dr. Peter Walsh, to do some introductions.
Well, good morning, everyone, and thank you for attending this session. I'd like to begin by thanking you for spending the time to participate, as us getting feedback in terms of the impact of this program is critical to us moving forward. We do want to begin with reviewing our mission. This has been our mission for approximately 2 years. We are working to improve healthcare equity, access, and outcomes for people we serve while saving Coloradans money on the healthcare and driving value for Colorado. This is our mission. If you could go to the next slide, please. And the goals related to Apm One are that we provide long-term sustainable investments into primary care. We'd like to reward performance and introduce accountability for outcomes and access to care, while at the same time providing some flexibility. And a final objective we have is to align this model with other payment reforms as appropriate. And while not directly related to the meeting today, our department has participated in a multi-payer alignment effort for several years now, and we plan to continue to do that in the future. So I'll hand it back to you, Nina, to continue.
All right, thank you. So in today's meeting, the topics of discussion will be the APM program review and updates. So that is a few points that stakeholders have reached out to us about in the last few weeks. We'd like to clarify for you. The department also has a few updates since we last met that they'd like to share. And then, as I mentioned, we'll spend the bulk of our time this morning around the topic of focusing the APM One. We have some aggregate performance data that the department would like to share, and to discuss some proposed changes to the program around measure selection, measure points, and the full measure set. In our next and final meeting, we'll talk about final plans for program year 2023. And as usual, what is not covered in these stakeholder forums are things around Medicaid program eligibility, attribution methods, or benefits like telehealth. So let's get started with the program review and updates, and I will pass it over to Zoe Pincus.
Good morning, everyone. Thank you for joining us all today. So to start off today, we just wanted to revisit a recommendation that we received in 2021 and was brought up in our last stakeholder session, which was that HCPF should explore measures related to social determinants of health and include those in the APM program. So we just want to give a brief progress update to our stakeholders, and that is that HCPF is looking to implement a social determinants of health topic into our RAY and managed care performance improvement plans beginning in 2023. So through this work, HCPF will explore data collection to help inform a statewide process in the future, which would mean having something to be able to put into the APM program. Next slide. So next slide, whoever's churning our slide deck.
Sorry, it's me, Zoe. Which slide are you hoping to be on?
The updates to the depression screen and follow-up.
Okay, that's not what you're seeing.
I'm still seeing social, oh, there we go.
Okay.
I didn't want us to keep talking if no one else could see what I was talking
There
about.
might be a little bit of a delay, no worries.
Oh, no worries. Sorry, everyone. So we also want to give an update on the depression screen and follow-up measure. So CMS is considering updating the depression screening and follow-up measure in 2023. It is a HEDIS measure that will not be an electronic clinical quality measure, but rather an electronic clinical data systems measure, which is a combo of administrative or claims data and EHR data. So if adopted, it will replace the current depression screen and follow-up measure that we have. However, we will not know the outcome of the adoption by CMS until December. So we will need to update our stakeholders on the final outcome once a determination has been made. But we want to be able to walk through this with all of you today, since this is the forum to do so. Next slide. So the measure as it currently is, or you can see the specs here on your screen. This is the current depression screen and follow-up measure, which is either an ECQM or an administrative measure, depending on which one you chose. And it is looking to be removed by CMS. And this measure applies to both our adult and our pediatric populations. Next slide. So this is the proposed new depression screen measure, which, just like the one we're using currently, has two parts with different goals for each part. And providers will need to close the gap on each part to receive full points. It will apply to the same population group, which is members 12 years and older. The main difference is is in the follow-up piece of the measure. So once a member has a positive depression screen, then they must receive follow-up care within 30 days of the positive depression screen finding. The way the measure is now is that a member must have a follow-up plan in place within 30 days, but not necessarily have received care within that 30-day window. So we will need to establish a new baseline for each participating provider if this measure is adopted into the CMS core measure set. So switching topics a little bit, this was another topic that came up in our last session, which was that people had concerns of access to timely data, and there was some confusion around when the data is supposed to be updated. So we have a handy dandy example on this screen of the performance periods and when data is accessible for each period. So HCPF has to give a 90-day run out for claims to come in, and that is a HEDIS recommendation or specification. It's not the department. So when we have a 30-day, and then we have a 30-day window for our vendor to process and run the reports. And then HCPF gets to post it to the Colorado Data Analytics portal within 14 days. So the 90-day requirement by HEDIS is a big part of the reason there is such a delay in receiving data. We are hoping this could be improved in the future. But as is currently, this is what we're working with, and HEDIS honestly wants a longer run out than just 90 days, but 90 days is what we agreed to. So if we will have this slide deck posted, but maybe it's a good table to save for reference if you're curious when you'll be receiving data. Obviously the years will change, but the dates and performance periods will remain the same. So we also just want to circle back on a few comments we heard in the last session about small providers participating in the APM. So PCMPs with less than 500 attributed members are currently excluded, but are able to opt in if they wish to participate. So if a provider is near that 500 mark and would like to opt in, then the department will work with the provider's RAE to make sure that they have enough data, especially for the mandatory measures, to support their participation in the APM. So after a data review by the department, we will make a decision and either allow or disallow participation in the APM. And I think it's important to note that providers who do not meet qualifications for the APM are still receiving that enhanced fee for service rate.
Hey, Zoe, maybe we could pause for a moment. We're getting a few questions about the depression screening measure in the Q&A. How will you let us know about the change? Can you confirm there's no change in the denominator used by HCPF for the proposed new depression metric? Yeah.
The communication, if this change is adopted, will probably be an email to all providers. We'll let the RAEs know as well, and the RAEs can share that information. So we'll know mid-December. We will know before we open measure selection. So we will not open measure selection until a determination has been made. If CMS does not adopt the measure the measure that they're proposing, we will use the measure we currently have. The denominator should remain similar, at least for the screening portion. And then I think the main change will be that follow-up piece, because it's expected that they receive actual care within 30 days as opposed to just a plan to receive care.
Great, and it looks like Dr. Walsh, would you like to chime in?
Yeah, I just wanted to point out that what we're trying to do is align this measure we were actually looking at this last year, but we were, as opposed to pushing to the current CMS core measure, we actually submitted a request to get the core measure set changed to include the current HEDIS measure, which is what we're proposing to shift to. We can't 100% promise what this will all look like when it's done, because, and we're hoping that if the CMS decides to shift to this measure, that they will also adopt the HEDIS specification entirely for a variety of reasons. It eases those organizations who could compute these for other reasons, and it's more consistent. But the short answer and the bottom line is, we won't know what the measure specification of this looks like until after they've made the selection. And because I know there was another question around what depression screenings are acceptable and what aren't. Those who are familiar with these metrics know those lists vary between the different measures. We'll use those allowed by the specifications. So I know that doesn't answer the question, but what I'm trying to tell you is we're trying to align with national measures, and also try to drive the CMS measure to be consistent with HEDIS whenever possible. So.
Thanks, Dr. Walsh. And I'm wondering if you would also want to comment on this question around follow-up within 30 days of a positive screen. Sounds difficult. Is that with a PCP therapy psych? Wait lists are much longer than 30 days with current resources. Do you have any thoughts on that right now, or is that also kind of pending the specifications?
We need to know what the final specifications are, but I think I guess there's two issues there. The answer is, it is some type of follow-up. There's a number of E&M codes that are used to calculate whether that was achieved. There's a code for screening, there's a code for the outcome of the screening, and those are administrative in nature. And then there's E&M codes that they then look for whether the follow-up occurred with appropriate E&M codes. So but the other issue raised is difficulty in getting individuals in within 30 days. We recognize that's difficult, but that the purpose of no one's going to achieve 100% on that instantaneously. That's not the nature of what's going on now, but we need to know what our state is and our current state is, and then we need to try to improve it. So it certainly will not be anywhere near 100%, nor is it nationally currently.
We have a few more questions coming in about this measure, so I think maybe we'll stay here for a couple more minutes. There's a question around if or how this measure will account for barriers to follow-ups due to behavioral health workforce barriers and access problems.
Sorry, it took a little while to get the mute button off. I think we need to separate from the measure will measure what is occurring. So, to the extent measures can. And so the fact that we measure something won't, de facto instantaneously change the challenges with behavioral workforce, access, staffing, and for that matter, for patients to be motivated for follow-up as well. But what it will measure is, again, what is actually occurring, as opposed to what is theoretically occurring in terms of a projected visit that may or may not happen. So Nina, I think the honest answer would be this will not resolve those issues, but it'll give us a better measurement of what our current state is, and then we'll have to set goals that reflect what our current state is in terms of performance, and then try to incrementally improve it. And that will not happen. I think most of you know there's substantial efforts underway at the state level to enhance behavioral health, I'll say access, and fairly, I don't want to misstate the degree of investment the state's making this year, but it'll take time for that to generate for there to be additional workforce, additional capability and practices. But this will not make those problems go away. This will measure them in a consistent manner that's consistent with, I'll say, what we don't want to do is push this program to a measure that is not consistent with what they're having to measure in other programs, hence the HEDIS push. Vice that did follow-up occur, or did we plan to do follow-up versus whether it really happened. So I know I'm not, but I just don't want to, mislead anyone. This will not, the fact that you measure something doesn't magically change the outcome. So.
I think through your answer, you've already kind of responded to this one as well. Will the department goal for the new measure be reduced given this potential change? Do you have any thoughts on the goals yet?
Well, I think that what we'll have to first of all understand is calculate what the baseline is, understand, and by the way, in general, we have a substantial opportunity to start with our current measure, but we'll have to understand our current performance. And as most people in the program understand, gap closure is the typical approach taken. It's not a change to a, HEDIS mean or a, raw percentile goal. So we're not proposing to change that methodology. So, and Zoe may have more to add on that because I know she works with Nicole and Nyberg quite a bit.
I was pretty much just going to say the same thing. I think it's just important to also highlight everyone will be measured against their own baseline performance with a 10% gap closure, regardless of what the state goal is for that measure, which we do not know yet. This has not been adopted. And so thus, unfortunately, we are unable to share what the state goals will be right now for each part of the measure. But once we know that, we will be sharing.
I want to highlight one additional question here that might be more of a food for thought. Would it be possible to publish preliminary data based off of claims submitted prior to the 90-day run out each month to help providers who are using this data for QI projects to have a general idea of how they are performing? And actually, that, I think, comment might be related to the timely data conversation, Zoe.
So that is a good question, and one I probably don't have a full answer to right now. Right now, we're unable to change that 90-day run out period. We do understand that the codes you're billing for as a PCP probably do not require a 90-day run out. Hospital codes and procedures and things like that are more where you need a run out. But this is established by HEDIS, and HEDIS honestly wanted to only run claims like once a year, and we agreed to every quarter. So at this time, that 90-day run out is not possible, or to shorten that. If we do adopt this measure, some of the goes into it is EHR data, so providers should be able to pull in and see where they stand, maybe with some of that with their own EHR data. But I do know, like the depression screen as it is currently, if you choose the administrative version, we do not give updates on it because it's an internally calculated measure. So that is something that we could definitely think about updating every quarter for those who choose it, and if it's possible.
Okay, thank you. All right, I want to just, for some people that may have joined us since we began, I want to just come back to the different ways in which we're asking folks to participate in the meeting today. So I'm seeing a lot of comments in the Q&A. We definitely appreciate your comments, but we'd love to keep the Q&A just for questions. So if you have a question for one of the speakers today, please use the Q&A for questions. If you have a comment that you'd like to share with the group, I welcome you to use the chat. So we will be keeping a transcription of the chat to be able to share. All of the panelists can see the chat in real time as well, but let's just use the Q&A for questions. And then conversely, if you're putting questions in the chat, we are not monitoring the chat this morning for questions. So if you've got a question, again, please use the Zoom Q&A at the bottom of your Zoom screen. All right, and then one final question in the Q&A here before I'm going to keep us moving. Do you think the final changes will be available in November or December? Any sense of the timing?
We don't expect to hear we typically, CMS typically transmits the letter regarding their decision on the core measure program in December, usually mid-December. They could change their mind, but that's typical.
Thank you. All right, Zoe, I will pass it back to you.
Thanks, Nina. So if you want more background information and the key concepts of the Apm One program, just another plug that we do have Apm 101 webinar on our website. So feel free to review that anytime you want. So we have heard feedback from stakeholders that practices should be measured on their year-over-year improvement and not on their own baseline. So, and not necessarily on that 200-point threshold. So while the APM is a point-based system, these points are earned and measured based on improvement from a practice's own baseline. So practices can earn potential credit or partial credit, for ECQMs and administrative measures. Administrative and ECQMs follow a close the gap calculation based on a statewide goal set by the department for each measure. So to receive full credit for a measure, PCMPs are expected to demonstrate improvement by closing the gap by 10% between their own baseline performance and the department's statewide goal. So PCMPs are measured against their own historical baseline rather than against other practices during the same time period. So if a PCMP's performance is at or above the statewide goal, the practice will receive full points for that measure. So in this example, partial credit is being earned in the first measure, and the PCMP earned 65% of the possible points. So 23 of the 35 points possible. The points a PCMP earns for individual measures are then summed to equal the APM quality score. So in this example, the total possible points for this PCMP was 305. But they earned 210 because they closed the gap by a percentage for several measures.
All right, so we'll move into the next part of the meeting today, which is around focusing the APM. There is some performance data that Zoe would like to share with you up front. That should help inform some of the discussion topics that we have for you today. If folks are ready to jump into the Menti, we're not quite there yet, but I will let you know when we have our first question and how to access that. So Zoe, I will pass it back to you to walk through some initial data.
Great, thanks, Nina. So we're really excited to be able to share.
Sorry about that.
That's
Hold
okay.
on 1 second. Okay.
We're really excited to be able to share some performance data from program year 2021. This is the first year that we have been able to calculate a rate change. And we're happy we were able to do this. COVID got in the way for quite a while. So for program year 2021, we had 366 participating PCMPs. And this graphic shows that less than 5%, or around 18 of the PCMPs did not meet the 200-point threshold. And that's that purple column on your left. So that means that over 95%, or roughly 348 of the PCMPs met the point threshold. The graph on this slide shows that 114 scored between 200 and 250 points. 116 scored between 251 and 300 points, and 118 scored greater than 300 points. 28 of the total pool of PCMPs were CPC plus, and thus they received an automatic 200 points. So that is included within those green bars. And then 48 PCMPs out of the total earned 100 points for being a primary care medical home or a PCMH. This graph does exclude our federally qualified health centers, if anyone was curious. So the total PCMPs participating was 366. 95% are receiving a positive rate increase, and 5% fell below the 200 point threshold. So, and the 5% that fell below the 200 points were not CPC plus or a primary care medical home. And about half of these PCMPs were exempt from 2022 program year. So they had fewer than 500 attributed members. And then 3 were exempt from 22 based on other extenuating circumstances not related to attribution. And then 8, or the other half, are participating in 2022. And then of the 18 that fell below the 200 points, the majority were located in the Denver metro area. So not our small rural providers. Next slide. Or maybe I should pause. I'll go to the next slide and then we can pause for some questions if there are any. So we kind of want to just evaluate structural performance data from 2021. So when it came to structural measures, 94% of the structural measures were passed. A little less than 5% had no data, and then 1.4% were failed. So a very small portion of structural measures were failed. Structural measure points accounted for 50% of the total points available in 2021 and account for 58% of the points earned. So this is a lot of people were passing the structural measures and a lot of points were earned from them. And then this is some just raw numbers for structural measure selection from program year 2022. So nearly 60% of PCMPs in program year 2022 selected 5 or more structural measures, which means that that is about half of the 10 total selected measures that a PCMP is required to report on. And I'll just pause here, Nina, for any questions.
Yeah, we have one that came in so far around the structural measure performance. How can there be no data on those structural measures? Does that not just imply failed?
Yeah, so it was a request. So the RAIs attest for PCMP's structural measures on their behalf. And so the no data is that they requested in our attestation survey that there be an option that wasn't pass or fail, but did not complete. So a PCMP didn't necessarily fail based on documentation, but they chose just not to complete the measure. It is technically counted the same way. They would not have received points for those measures. So this would be almost, a little over 6% if you just want to look at it one slice of the pie instead of 3 different pieces.
All right, no other questions coming in right now. So why don't we keep moving to our discussion topics for today?
Sounds good.
All right, back to you, Zoe.
Thanks. So over the next few slides, we want to gauge how important some of the department's priorities are to our stakeholders. So we've heard that the Apm One is too broad, doesn't have enough focus on health outcomes. There are too many measures. There's lack of alignment with other programs, and that the Apm One is administratively burdensome to some participants. So The next few topics, we'll kind of dive into each of these. I guess I was maybe muted for some of that, so sorry.
No, sorry, that was me. I was just trying to add myself and unmute myself, and I accidentally did it to you instead. But
Oh, no worries.
all right, so we've got, we want to pause here to see what you all think about these priorities. And so I'm going to switch over to Menti. So if folks can join me at www.menti.com. And I think Ashley is going to be adding this into the chat as well. The code to use is 8963-5962. If you're not able to use Menti this morning, no sweat. You can tell us what you think in the chat and we'll capture it there. But we want to hear for each of the 3 priorities that Zoe mentioned, how important do you think that they are to the APM1? Focusing on priority health outcomes, alignment with other state and federal initiatives, and low administrative burden. And if anyone has anything to share verbally, we welcome you to raise your hand if you'd like to share with us over the line. Would love to hear from you. So we can see some results coming in. It looks like folks do feel like these 3 priorities are important. Maybe low administrative burden is taking the lead for now.
Hi, Nina, this is Simon. There are some folks with their hands raised, so I am going to invite you to participate if you have your hand raised. So Brian, I just invited you to speak. I can ask to unmute.
Brian,
yeah, sorry, I must have accidentally.
No problem.
Oh, no problem. All right. Elizabeth.
I should be muted again.
Elizabeth, if you can hear us, we'd love to hear from you.
Yes. Hi, can you hear me?
Yes, we can.
Great. Okay, fantastic. Thank you so much. This is Elizabeth from Children's Hospital. I use she, her pronouns. Ranking these priorities is a little bit tricky because, well, for a couple of reasons around implementation. So one is that lack of alignment with other state and federal initiatives creates the administrative burden. So the second 2 are interrelated. I mean, it's not 100% overlap, but it's pretty significant. And then focusing on priority health outcomes. I mean, that should be the goal, right? That's the point. But because of the administrative burden and the lack of alignment, and because of the rapid, and this is feedback you've heard, right? The rapid cycle of program changes, it's very hard to get to the priority health outcomes, right? And so we don't necessarily have a clear line between a clear cause and effect line between the way these programs are implemented and the outcomes they're supposed to achieve. And so, you know, I just, for the sake of it, I said 5 on all 3 of them because they're all really important. But I guess I would, I would perhaps frame it a little bit differently, rather than asking if priority health outcomes are important, which they are. I don't think you could get a disagreement on that. It might help more about, I don't know, like the feedback might be more about strategies for achieving that within the program.
Thank you, Elizabeth, for sharing.
And Stephanie.
Yeah, hi. I want to echo what was just said and then build on it to say, I also think that the administrative burden gets in the way of the priority health outcomes. I am already struggling with the fact that the depression measure is measured multiple ways by various peer incentive groups. Like our KPI is based on the G codes, and when I report to UDS and APM, it's based on the follow-up plan being in the note, and reconciling that with a group of providers that is overwhelmed by already doing unnecessary clicks, and then potentially saying to them, hey, I know we're measuring this 2 ways, now we're going to measure it a 3rd different way, and really a 4th way, because we're also measuring remission now through the UDS. It's just overwhelming, and it really prevents you from focusing on health outcomes, because you end up putting your efforts as a QI team on just capturing good data and getting credit for the work you're doing at baseline, that it distracts you from really being able to focus on the patient and ultimately interventions that are going to move the measure. And you find yourself kind of caught more so in how are we capturing the data? How are we going to streamline the workflows so that they all align with these 4 different measures?
Thank you, Stephanie, for your feedback. Someone, do we have anybody else in the queue?
No, those are all the raised hands I'm seeing. Thank you, everyone.
Okay. Well, thanks to those who were able to participate in the mentee. I think that the outcome that we're seeing here is that folks are in agreement that all of these priorities that the department has identified are important to you as well. And so we will keep moving kind of with these in mind. I think, yeah, just keep these in mind as we continue the discussion. So I'm going to bring us back to our presentation and pass it back to Zoe.
So we have heard in the past that the APM has too many measures. So one of our proposed recommendations for program year 2023 is to modify the measure selection and reduce the number of measures a PCMP reports on to 6 measures instead of 10. So we will still have the 3 mandatory measures, and then we think this will allow PCMPs to focus more on health outcomes and hopefully help reduce some of that administrative burden that we just talked about. So I'm sure you're all thinking, how will this help? How will this impact points? And how will they all add up to 200? So we will get there, I promise. So please hold any questions you have on that for just a few moments as we kind of work through some more questions. So with that, I believe we have another mentee question or discussion.
So keep in mind, as Zoe just mentioned, we're not talking about math yet, right? We just want to think about reducing the number of measures that PCMPs are required to select and report and improve on. So our next question in the mentee, we want to start with just a general pulse check of the group if you would support a reduction in the number of measures that each PCMP reports for Apm One. So that's a reduction from the 10 measures that are currently there to 6. And remember, 3 of those measures are mandatory, so you're not selecting those 3. In the new proposal, with 6 measures total, you'd be selecting 3 measures, and then you'd have the 3 mandatory measures. So get at us in the mentee with your thoughts here, and then we'll open up the line for any questions or comments. And I'll ask my colleague Suman if we've got anyone in the queue to speak.
Yes, we do. David. David, I think you'll need to take yourself off mute.
Yeah, I was trying to, it wouldn't do that.
Oh, well, we can hear you now. Sorry about that.
Yeah, I don't know, there's something weird in the thing. I was also trying to lower my hand there,
Oh.
lowered my hand. Yeah, I think that the right answer is, I think we'd all love to see fewer measures, but it depends on which measures you're going to leave behind. Because what that does is puts a lot more weight on each of the measures. And I think so it's kind of a combined, it's in some ways it's a trick question. We'd want to be sure that the measures that we're being held to actually capture in some way the nuance and complexity of the care that we're providing, right? Because any single measure we know is a really poor descriptor of what we actually do in primary care in real life.
Thanks, David.
I'm not seeing any other call-in listeners at the moment, or participants at the moment.
Okay. Well, I'm going to keep us moving to our next question for discussion. Same topic. Oh, my apologies. So, okay. So the first question was gauging whether you supported a reduction in measures across the board. Now this question is specific from 10 to 6. So if you feel free to answer the same way. I'm sorry, I didn't quite tee up that first question in a different way. So these feel very similar right now, I know. But similarly, if you support reducing specifically from 10 to 6 measures total. And so we'll pause here for a moment. We've got a lot of folks showing some uncertainty and would love to hear from you if you are uncertain. If you want to share something in the chat, or if you'd like to share with us verbally, if you want to raise your hand, we'd love to hear from you why you're feeling uncertain about this proposal.
Okay, we have a few folks. And Hoke, yes, I think you should be able to speak now.
Thank you. So I think the uncertainty here reflects back to David's last comment, okay? The overall thrust of what we're trying to achieve is to improve primary care. And that really depends upon, can we fund primary care? And funding for primary care, now is being equated with how you perform in your APM. So if you're asking, gee, I'm not sure, what those 6 metrics will be, and you want me to reduce from, 10 to 6, that leaves you 3 that you can actually, from your practice point of view, accommodate to benefit your ability to meet the goal to receive funding. Okay, I suspect, I don't know this, but I suspect that in the past, most PCMPs met the measure based primarily on structural metrics, and this is a big change here. I read forward, and there's a concern to take out those structural measures. So I think that's the uncertainty here.
Thanks, Hoke. And kind of to something that Hoke raised around the mandatory measures, and then we've got a question in the Q&A. Zoe, if you could help out, are the 3 mandatory measures going to change yearly, or are those something that PCMPs can kind of count on?
I can't speak to like the long-term future, but for this next year, it is our intention to keep the same set of mandatory measures with the possible just change of the depression screen measure. So the depression screen and follow-up will remain a mandatory measure, but the definition of it might change based on adoption by CMS.
Thanks. Seeing some comments in the chat around some uncertainty related to the point totals. And as I think we mentioned earlier, if you're like me, you're trying to do the math on this, and we're not talking about math yet. So we just want to think conceptually about the program, right? We'll make sure that the math works out, whether the point values change for specific measures, whether the that 200 point total is changed. Those things are on the table down the road. Don't worry, the department, I think, wants people to succeed in this program as well as improving health outcomes. So they'll make sure that the math works out, and we'll get back to you on those details. But we really just want to get a sense from folks how you're feeling about just the concept of having only 6 measures to work from instead of 10. So I hope that answers some of the uncertainty around the math.
I also think it's important to point out that if you're a primary care medical home accredited or an FQHC, you already choose 6 measures and not 10.
All right, Summon, do we have anybody else in the queue?
We do not.
Okay. So our last question for you on this topic, which I think we're hearing from you on this already, but if you haven't had a chance to weigh in, we'd like to hear what unintended consequences might the reduction in number of measures selected cause. So the department wants, let's poke some holes in this for them, right? Are there any unintended consequences to having 6 measures total instead of the 10 that you'd like to raise for them? So this is an open-ended question and mentee. If you have any thoughts and you haven't had a chance to share yet, we'd love to hear from you there. And the line is still open for verbal questions and comments if you want to share that way. So we're getting some good comments in the mentee. Concerned about leaving out important measures related to equity. Fewer measures might mean fewer opportunities for reaching point goals. That's a math comment, so we're going to leave that one for now. Worried about more providers failing, less opportunity to get credit, less chance to reach targets. Let's see. It depends on what the measures end up being, so unable to really answer this question. We're seeing a lot of comments around points. So we're going to keep those in our back pocket for later. Comment around the whole practice is geared towards leveraging these programs for funding. If we only fund a few things and the admin burden is too great, the practice may need to narrow its health goals. Essential key is implementation. I think that what I'm hearing is that the idea with this proposal is to reduce the administrative burden on practices. So would love to hear from folks if you feel like this is increasing the administrative burden. Let us know what you're thinking around that. Let's see. This is some things may just get forgotten as they are no longer seen as important. So that is something to keep in mind. And teaching to the test, similarly, focus on the targeted areas means that areas not identified as measure priorities are less likely to be addressed. For example, if there's no focus on developmental screening. Small practices may not be able to participate if the measures don't apply to the services that they offer. I think that at this point, We're not putting any changes to the measures on the table. So we'll come back to that thought. If you're concerned about the measures not applying, hold that until we get to the discussion around the measure set.
I think we're going to address a lot of these concerns or comments in the next few slides. So thank you everyone for sharing. It's super valuable, and I think this will just help our discussion moving forward.
Yes, so we will be capturing all of these comments and sharing them with the department in follow-up. Again, I'm seeing a lot about significant administrative burden, but I would like to hear from folks specifically how reducing the number of measures would increase that burden. I mean, right now, right, the program is not changing. You still need to select measures and report on them in the same way. It would be selecting less measures. So some of the comments around administrative burden, we'd love to hear from you why you think that might be increased. But as Zoe mentioned, I'm going to keep us moving to the next section, and hopefully we'll get some more clarity. So Zoe, back to you.
Thanks, Nina. So in addition to proposing to reduce the number of measures, we are proposing to increase the point values for the measures, which are determined to be priorities by the department and are included in the department's health equity plan. So we will get to this list in a moment, but HCPF thinks this will help bolster the points earned by a PCMP given the proposed decrease in the total number of measures selected, and will incentivize providers to focus on measures that they might not otherwise choose, but are considered very important to the department. So as HCPF has heard from stakeholders in the past, pediatric practices have less measures to choose from. So we do think that pediatric measures are part of this list that we'll share in just a moment. But that increasing point values for some of these for the pediatric population, as well as for some adult measures, will be received well. So I do believe we have another mentee question or two related to supporting increasing measure points for some priority measures.
All right. Well, moving on to the next question. And this is, would you support increasing measure points for priority measures? And keep in mind, we don't know by how much yet, so don't be thinking about the math on this question. We don't know which priority measures we're talking about, right? So those are both caveats. But in general, would you support increasing measure points for measures that are a priority to the department?
And while we're answering that, David, I saw that you'd raised your hand right as we were transitioning off the last slide. So I'll allow you to share your comments now if they are still.
Sure. No, that was about the question of administrative burden. So there's, I think we all look at administrative burden in several ways, one of which is the reporting burden that I think you're saying by reducing the number of measures, we will decrease the reporting burden, which may be true. But also there's the refocusing of our practice around those measures and the burden of changing our QI processes that are currently in place. So I think that's maybe some of what you're hearing is just an understanding that anytime those things change, that causes a ripple effect through our practices in what we consider administration. And what we consider administration is anything that doesn't have a patient in front of us. So I think that maybe part of what you're hearing is that we define administrative burden quite broadly.
Thanks, David, for sharing that.
You.
Would love to hear from folks around uncertainty. We have a lot of folks who are feeling uncertain about increasing point values for priority measures. Would love to hear from folks with any thoughts on this.
Yeah, and Elizabeth.
Yes, hi again. I want to go back to something that Hoke said earlier about the need for general funding. So in pediatrics, right, the practices need general funding in order to implement all of the quality things. And so this kind of circular funding model where you're incentivized to improve on one thing and then you don't get the funding to improve that one thing until you improve on that one thing isn't necessarily the most effective way to improve care. And so I think from me, and I am speaking as a policy person and not a clinician, my uncertainty is around that. It's around, I think Dr. Keller phrased it as teaching to the test. So I think those issues are really important in kind of a broad way around these programs.
Great.
Thanks for sharing. I'm going to keep us moving to the next mentee question while we take the next comment.
Yeah, and Hoke had a comment as well for this one.
So I think, again, the uncertainty is because you really can't answer the first part of the question until you know what those priority measures are. So again, if you read forward and you look at that, there are specific issues with how you look at those priority metrics. And until you answer those questions about the specifics of the priority metrics, it's hard to say, yeah, I'm willing to decrease the number. Now, in all honesty, I voted yes. I would like to see a decrease in the number of metrics, okay? I think we're as Elizabeth said, get money to people so that they can increase their access to these patients and do a better job. In our network, the biggest hang up for all of our practices is that they can't fund their current staff, and they can't find staff because they can't fund them appropriately, okay? Until we improve that situation, it's really hard to focus on some of these other issues around metrics.
Thanks, Hoke. All right, well, I think folks are ready, Zoe, to hear a little more about what you are thinking around the priority measures. So I'm going to throw it back to you to walk us through our next couple slides.
Thanks, Nina. So we've been building up. So I know some people read ahead, which is great. And so we're finally sharing with everyone who has not read ahead what we're proposing as far as priority measures and point increases for those measures. So the department is proposing to increase the point values for the mandatory measures and a list of other priority measures outlined on the following slide. And we will be keeping the same list of mandatory measures as we did last year. So you can see those on your screen. And I know we're not sharing right now our proposal for the point increase, but these measures are also in the department's health equity plan. They are all CMS core measures, as well as the small list on the next slide as well. Nina, if you want to scroll to that one. So these are the measures we are proposing to increase point values for, and that are priorities for the department. And I know we're kind of using priorities and mandatory interchangeably. This whole list, so the slide before and these ones are all priorities. There is a long list that are mandatory. So with that, I think we can move on to our mentee question, which is, would you support increasing the point values for the following priority measures? All mandatory measures, and then the 3 additional measures. So agree or do not agree.
All right, so we'd love to hear from you on the priority measures that Zoe shared. Ashley also just dropped in the chat for your reference if you need the full measure set list. If you kind of want to compare and contrast what's being proposed here with the full list of measures, that's there for you. And we can take a couple comments if we have any.
Yeah.
Sorry, I'm gonna, if I could go ahead, there was David Keller asked a question, but I will just speak to.
Sure.
So there are more in that list. You're seeing quite a few measures. So how it was last year is like there were 3 different immunization measures and a practice chose one of them. There were 2 well visit measures, a practice chose one of the 2. So because we don't know the, which ones practices will choose, we are proposing to increase point values for all of them so that if you chose either one of the well visit measures, they're worth the same points, as are the 2 diabetes measures.
And so Zoe, even though that list is all mandatory, there's still some ability to shift based on your denominator or based on your population or your ability to report on ECQMs, for example, right? So that's
Correct.
why there's some variability in that list. Okay.
Let's see, Brian, did you have a comment here?
Yeah, so I guess my comment is specifically on the mental health hospitalization follow-up. And it's not that I don't view this as a priority. I think this is an unbelievable priority. But there's some fundamental system issues, again, here that PCPs are being held to that I find really difficult to overcome. But relatively consistently, we're not notified about inpatient hospitalization for mental health until the family comes to our office, either presenting again in crisis or needing refills on medications that were not, adequate. There wasn't an adequate follow-up plan from the inpatient side. And, until there's some responsibility or a better way to kind of communicate those hospitalizations to the PCPs, if we're going to be the ones held responsible for this, I find this measure impossibly frustrating.
Thank you, Brian, for sharing that story and that feedback. And totally welcome. And I just want to remind folks too that just because the point values for these measures are being increased, they're still optional. So this would still be part of your selection. The mandatory measures, the department wants folks to focus on those three areas in particular. This follow-up after ED visit, after hospitalization and lead screening in children, those measures are still going to be optional for selection, and appreciate your feedback on if you feel like this is a priority measure to the point where it would be worth more points for practices.
And I think some of the main reason we chose some of these measures is to get more reliable data and increase reporting on them. The 2 follow-up measures were not chosen as frequently, but we do find them important and they are in our health equity plan. So that is some of the reason for the list you are seeing in addition to the mandatory measures. But it is up to each PCMP if they choose to choose any of these 3 measures. And there was a question about fairness between pediatric and adult practices. And the 2 follow-up measures do apply to pediatric practices. I can't remember the age cutoff or age range, but they do apply to pediatrics as well.
And Hoke, if you would like to share your comment.
And before we go to the next comment, Summon, I'm just going to keep us moving. I think we've kind of leveled out on this mentee question, so I'm going to move folks to the next question. Surprise, if we could hear from you, any unintended consequences around the change in point values for those measures. If you could share your thoughts in the mentee, if you haven't shared already, or if you'd like to speak to us verbally, and Hoke will be glad to hear from you next.
Yes, thank you. I agree 100% with Brian. Until notification of discharge from a hospital is routine and timely, it's almost impossible to perform well on those follow-ups. Back to some of the mandatory measures, okay? So for immunizations, I think it's a great measure, but again, a lot of providers perform relatively highly in these areas, but may not be meeting the goal. And so the ability to do the 10% gap closure becomes harder and harder as you get, further, as you're performing better and better. So I think you have to consider, that as kind of an unintended consequence there. For the child and for the well visit categories in general, this is really an attribution concern. So I know we're not talking about attribution, but until we have attribution better defined and better controlled at the primary care physician's office, those are difficult ones, again, to really have good control of. Finally, on the asthma medication ratio, there have been significant changes in how we, on the recommendations for asthma treatment. And so that medication ratio is really going to be impossible to really effectively manage, okay? It just doesn't work anymore.
Thanks, Hoke. We've got a question in the Q&A, Zoe, or anybody from the department team. If the purpose is to get data, why use a model that potentially punishes practices for not having that data or achieving those goals? Any thoughts on that question?
Our goal is obviously not to punish a practice if they choose to do that measure. A practice would definitely need to look at their baseline data to determine if it's feasible for them to do it, such as having a denominator greater than 30. So if you do not have a denominator that supports you selecting that measure, I would not recommend selecting it. These are just proposals by the department. Nothing is set in stone. So we appreciate feedback on these. And we'll take that back internally, obviously, for discussion. So none of this is finalized. These are just proposals. And our goal is not to disincentivize or harm practices for choosing these measures.
Thank you. Okay, let's keep moving in the presentation. This mentee question will stay open if folks want to continue putting any feedback in there. And so I think I'm passing to Dr. Walsh to present this next couple slides.
Yes, and so I've been sympathetic to the perspective of unsure how to comment on the prior proposals, because you really need to have, I think, all of these issues discussed to really pull it all together. But one of the one of the changes we're considering is to shift away from structural measures in terms of selection. And so obviously that fits into the question of reducing the number of measures that came up previously. Structural measures were obviously part of the program launch in 2018. And if you read some of the early program documents, the original objective was to actually phase them out, I think a year or two prior to this year. However, COVID slowed that process, and the program development took a little longer to evolve than all thought it would. But we are considering this, and we're interested in feedback our perspective is these are not unimportant. And however, we're trying to shift away from, I'll just say structural measures to actual metrics. And that's obviously part of the previous conversation. So I know this is a major change and we're interested in your feedback on it.
All right. So the question for the group on the table is if you support removing structural measures from the Apm One set. And so I'm going to move us to our next mentee question. If you could share with us your thoughts. And this is keeping in mind some of the other proposals on the table that have been discussed today. So reducing the number of overall measures, right, from 10 to 6. You saw some initial proposals around increasing point values for priority measures, for those mandatory measures, and the additional 3 measures that were discussed. So kind of keeping all of those things in mind, as well as the goals of the program. We'd love to hear from you, your thoughts on removing structural measures. And we invite any comments in the chat or verbally if folks want to share. And especially those who are unsure at this time, we'd love to hear a little bit more about your uncertainty.
And let's see, David.
Yeah, sorry to be talking so much. I think that one needs to consider the point of the structural measures, and that in a lot of ways depends on where a practice is on the continuum of transformation. You know, if you're a traditional fee-for-service practice and you're just starting the journey, you're unlikely to move right away. Performance measures, the measures of performance, you're going to need to be building infrastructure. So what the structural measures do in a sense is facilitate the early transformations of practices that are starting out, whereas practices that are higher functioning are able to perform on the performance measures and don't really need them. So I think part of the problem is that we've lumped them all together into a single bucket. Because really the 2 different kinds of measures serve 2 different functions in the transformation process. And I think that's, so whether you'd eliminate them or not really depends where you are on the practice transformation continuum, and how much you're able to influence measures, which, is an ability that requires infrastructure. So anyway, for the department may want to consider a developmental approach to this and thinking about practices in different stages of development as having different needs.
Thanks, David. And Dr. Walsh, did you want to respond?
David, I appreciate that feedback, and that's something we'll definitely consider. We're obviously considering everything, but I do appreciate the feedback.
Okay, and Brian, I will unmute you.
Yeah, so I mean, I concur with David. I think the other thing is that the structural measures potentially going away, it just adds to the overall feeling of the instability, right? Just kind of constant change in marks and measures. I think pivoting and making those changes are significant, time and resource investments for practices. And so when we're talking about measures going away, I think it just adds to that. And so, if these measures are going to go away, I would really like to see this commitment on the other side that whatever we're striving for is actually going to be stable.
Thanks, Brian. Do we have any other folks?
We do not, no.
Okay. Well, if you didn't get a chance to weigh in on your thoughts here, would love to hear from you in the chat, but I'm going to keep us moving to the next mentee question around any considerations for HCPF or concerns about removing structural measures. If you haven't shared with us verbally or in the chat already, you can rest assured that we've captured your comments and thoughts there. If you'd like to share anything additional in the Mentee, now is your time. I'm going to leave this open and move us. We've got one more discussion topic, and then I want to make sure that we save a few minutes for public comment and get everyone out of here on time. So Zoe, I'm going to pass back to you to take us through the final discussion topic.
Thanks, Nina. And I guess just to kind of wrap up this conversation on our proposal to remove structural measures, some of the reason for our proposal, as Dr. Walsh has said, you know, they're just kind of, they are process measures. They are somewhat subjective in you passing or failing them. PCMPs tend to choose 2 to 4 of the same structural measures year over year. And so that makes it kind of hard from the department's perspective to continue some of those measures. It is hard for us to then pinpoint and make PCMPs choose different structural measures year over year. But so, you know, we've had a lot of the same structural measures since the beginning of the APM. And I know the list has shortened over the years, but PCMPs could have been choosing the same structural measures technically since like 2017. So that just makes it, you know, we want to shift more to health outcomes, which are our ECQM and administrative measures. So I will leave it there and switch topics to wrap us up. But we do have one last proposal for an addition to the measure list to continue the department's alignment with CMS core measures, and that if adopted, we will be adding this measure to the measure list. And it is this adult immunization status measure. And it is the percentage of members 19 years of age and older who are up to date on the recommended routine vaccines for influenza, tetanus, and diphtheria, or tetanus, diphtheria, and acellular pertussis, or Tdap, zoster, and pneumococcal. So if this measure is not adopted by CMS, we will not, which we will not know until December, we will not be adding it to the APM list of measures. And this is kind of just some specs on it. If we can go to the next slide, there's a little more on the measure. So here's just a little more additional detail on the measure for the numerator and denominator piece. So this is a 4-part measure. So we will have a different goal for each part of the measure. And a practice will need to improve on all parts to earn full points, just like some of our other measures like this. So each part would be worth 25% of total measure points. If a practice does not have a denominator for a part of the overall measure, so for example, the immunization status for pneumococcal, because the members that fall into this are 66 years and older, so they're not necessarily only Medicaid members, then the measure would be broken only into 3 sections instead of 4. So full points would still be possible. So if you have no members in a denominator for a part of this measure, it would be, the points would be redistributed. So you would still be able to receive full points even if you are unable to report on part of the measure. So with that, I'll turn it over to Nina for our last Mentee question.
So I'm going to open this question up for feedback, but I'm going to, and folks have already begun putting in, so thank you. What concerns do you have with adding this measure as described into the Apm One Measure Set? So as Zoe mentioned, this is not yet finalized, but if it is included in the CMS Adult Core Measure Set, what concerns do you have with including this particular measure? And so I'm going to leave this Mentee question open so folks can continue adding in there. And I'm going to just keep us moving on our presentation to make sure that we get everyone out of here in the next 5 minutes. So continue to answer that question in the Mentee. That will stay open. I do want to open the floor for any public comment. If folks have anything that they didn't get a chance to share today relative to the discussion topics or something else that's on your mind, you can share comments and questions verbally or in the chat. If you're sharing a comment regarding something that's maybe not related to our discussion topics today, we ask you to share your name, organization, and disclose any financial interests if appropriate. So would love to hear from folks if you have any feedback on the immunization measure that we were just talking about or anything else. We'll open up the floor for a few final comments. So you can reach us in the chat, or if folks want to raise their hand, we can unmute your line. We do have a question in the Q&A. The year-over-year changes in the program are part of the administrative burden, so thanks for pointing that out. I understand they are necessary due to the program rollout. When does the department think the program will become more stable year over year? Any thoughts to share?
I'll take that, or part of it anyway. So we do know all these changes probably give people a headache. It's hard to keep track of. There were some big changes that happened last year. And I think some of the reason there's been maybe it feels like more of a progression over the last 2 years is that it was a slow buildup to the APM in general. You got full credit for participating, and we didn't calculate rate changes. And then COVID happened. And so the program was kind of on hold for the last like 2 or 3 years because of COVID and the impact it's had on our providers. So we get that it probably feels like a lot, but we are trying to get to a place where it is more stable and more predictable year over year. And I do think we are getting to that point. It was an intention all along from the creation of the APM to phase out structural measures. I think by 2020, and we kind of laid off on that based on COVID. So some things we knew up front we would eventually get there, and then some things, got in the way. So I'll allow anyone else from the department to speak to that, or anyone else if they wish.
Thanks, Zoe. And I'm not seeing anyone else for verbal comments and no other questions in the Q&A. We did get some feedback in the chat regarding the immunization measure. And I know there is some feedback rolling in the mentee, so thanks for that. Any other final comments before we close? All right, well, I look forward to seeing you all again for our third and final community forum on October 13th at the same time. Please be sure to register for that meeting if you haven't already. Remember, you need to register for each of these forums separately to receive your Zoom login. And we will be in touch with more information before that meeting. Welcome any comments in the meantime to focusgroups@coloradohealthinstitute.org. All feedback that we receive through that email address, we do share directly with the department. So thanks everyone for joining today. We appreciate your time.